Okay, the last one, challenge your eyes, educate your eyes. So I will show a lot of video clips to test your eyes. Okay, case scenarios. So before we start, I would like to propose a concept. When we scan every areas from the head to the toe, maybe we can have some kind of mnemonics to remember what to look at. But it's only a preliminary concept. Safe remove. Scan for what? Safe remove. Move your probe safely to search for those kind of things. Is the air? Where is the air? Is the air normal, abnormal? And the size, the fluid, and even the content. Echogenicity, solid organ, hard organ. The regional abnormalities for the motion, the lung, the IVC, the peristalsis of the intestine, even uh, the, the heart beating. What can cause the obstruction? The vessels, the GI tract, the biliary tract, the urinary tract, and don't forget to look for the vessels. But especially for adult patients, we got a lot of obstruction problems. But for the pediatric, it's less common, right, compared to the adult. For the equality, especially for the heart, for the lungs, and all the musculoskeletal system. Why? When you see something wrong on the one side, you're not sure. Scan the other side to see if that is equal. So let's start train your eyes. What is this probe? What type of this probe? Linear, easier, right? What is the target organ? Eyes. So choose the linear probe because got better resolution and to see the shallow part. The eye is shallow, right? So what can you see? The equality. So when you scan the eyes, you are not aware of the abnormality. So what is the comparison from the right eye to the left eye? What do you see? Not so equal, right? So the patient's eye got some problem. Normal eye. What is the problem? The size become smaller, right? Irregular shape. The patient's got trauma here. So it's kind of eyeball rupture. So be prepared not to compress the eyeball. Instead, use copious gel and rest your hands and the probe without touching, right? Just to touch the gel. So you know the target. You want to find the problem. Use the correct tools and also don't remember to compare the normal side. Then you can find out what is the problem. So what is the problem we are facing? The patient got a swollen neck. So a girl for 7 days. What is the mark for? The mark means the girl's cricothyroid member. So deviate to right side, obviously, right? So if the patient developed dyspnea, airway problem, it definitely a difficult airway instead of the traditional one. So let's see how ultrasound can help us to find the problem. Transversely, the liquid, right? Motion echogenicity inside the liquid. It's called squeeze sign. So we know that it's kind of dirty fluid. If that is clear fluid, it should be anechoic. It's echogenic fluid, got motion particles inside, so it's something wrong. And most commonly, red fever leukocytosis is pus, abscess over the neck. And then we scan from here to right transversely. The structure you are familiar with, right? What is this? Trachea. Trachea to the right side. Okay, I can see the whole picture. Where it is the trachea and how far away from the midline it is. Then the last question, I have to prepare. Despite these patients breathe normally, but I have to prepare. So that's why I do this scanning. What is this structure? Cricoid, thyroid cartilage. And this is the cricoid thyroid membrane. So I can locate this in case if the patient needs the surgical airway management. I can find this instead of to do ultrasound again. I can mark here. So that's the ultrasound can help us find the pathology, define the problem, and even make you a safer way to do some kind of procedure. In this case, maybe the tracheal thyroidotomy, right? But because this patient got no obviously not impending airway problem, respiratory failure, so I will leave this management to the OR for the surgeons to do the drainage and to manage the airway. But as you can see, if the patients develop some kind of problem, we can manage this kind of problem at bedside ICU and in ER to drain the abscess, to release the pressure, and even find the airway, right? So that ultrasound can help to answer your question because you face the question, so you need to find what it can help you. This probe, the quality is not so high, right? Because I use a pocket-sized ultrasound. With pocket-sized ultrasound, you can put a stethoscope in your one pocket, the other one in your the other pocket, and to see the patients, listen first, and then to scan. Oh, what are you doing, right? Fantastic. So the mobile period era is coming. Then, because we have to provide the highest quality of videos to demonstrate, so let's see these patients. A teenage young boy got neck and chest pain, no trauma. Let's see, what do you see? Anything wrong? This should be neck, right? Linear to scan for the neck. Some structure you are familiar with, the vocal cord, the trachea, and even the thyroid gland. What is the abnormal finding? Really lymph nodes? If that is lymph node, then I will be a bad presentator. Why? Because I have to keep the lymph node clear to demonstrate the structure. What do you see? Where is the abnormal finding? Can you see all the anatomy clearly? Why? Because you are blocked by some shadow, some artifact, right? What is the artifact? Air. I scan only on the upper, the lower neck instead of the lung. Because if I'm scanning the lung, you will see the baseline. You will see the pleura. That's where the air should appear in its normal position. But right now, from this side, the small air, then mask all the trachea, then mask the carotid, jugular vein, even the left side. The vessel is blocked by those kind of hyperechoic with coming tail, right? Sometimes we just need to describe it then to find what is the problem. If that is hyperechoic and with shadow, we know that some kind of hard material, like foreign body, like bone, like stone, but that's hyperechoic with shadow, similar like the finding you observed in the lung section, right? So, is that so obviously? No. Difficult to find, right? Here, pneumomediastinum, and here, difficult to find compared to the ultrasound finding, because we use linear one, we amplified the finding, make it easier to see the superficial part. And this, can you see? Last month, we got a girl, 4 months old, then got dyspnea, and the saturation is 70. And then the father just brought her in and got blue face and difficult to breathe, and we have difficult to set the line initially, and we cannot ventilate baking adequately because the girl still struggling to breathe. So we intubate the girl. Is the intubation in correct position or in no? Right? Why? Because we can see double track, right? See the double track. So no more baking. Just pull the endotracheal tube away because it is in the incorrect position in the trachea. So we try again. This time, are we successfully to intubate the tube? Because the previous one we failed, then we do it immediately. And this is what we do. So this time, trachea or esophagus. Correct position? Correct. Correct position? The patient is not paralyzed, so still got struggling breathing. Right? So we cannot see double track. Some air here, you can see this because of the swallowing air instead of the air track consistently appear. So this time we did a great job. So after we put the tube in, can we confirm it directly? For the neonate, for the young patients, we can. See, we use linear probe and to see sagittally, longitudinally, the trachea ring, and this is the catheter, right? The endotracheal tube, longitudinally, so we can see the tube really inside the trachea, longitudinally and transversely. So see, the esophagus is collapsed without double track. So we can manage the airway immediately and to not to confirm later on by ambubating and to confirm by the entitled CO2. Because if you, it depends on the capnography, it needs you to baking for maybe 6 ventilation to get a good reading to confirm that. What is the problem of this patient, this girl? After we sedated, because we intubate, we feel safe to give the sedation and muscle relaxant. Then, what is the problem? So we need to find out. This is the problem. Cystic component and some echogenic component. The vessel is no problem because we can demonstrate the vessel and use the Doppler function. I'm not show the video clips here. So the vessel structure is normal. So my colleagues, pediatric colleagues, told me that hemangioma lymphangioma. Okay, the first time I met this kind of disease, but I know that it is a cystic component with some echogenic component. So despite I am not aware of this disease, I know that is a problem to cause the patient's condition. So, challenge again. What is this function? What is this function? Color Doppler. What kind of color? Power. Power Doppler. Only one color, right? So, if you are trying to use the color Doppler, that means you need to know the direction of the flow. But if you are trying to detect only the flow with flow or not, or to detect the reduced flow, we use power Doppler. Power Doppler is quite essential for emergency physicians because most of the situations we need to detect with flow or no flow because that's emergency problem. What is this kind of artifact? Mirror artifact. Every time you encounter a hyper-reflected surface, you will face the mirror artifact. How to resolve it? change the direction and change into the other view, and it would disappear. Now, challenge again. 19 years old boy got trauma. Normal or abnormal? A linear one, scan on the right chest. The patient's got chest pain and difficult breathing. Normal, right? Sliding, smooth surface with A line, no problem here. So shift to the left chest. Sliding, no sliding, lung pulse. Do you think that's really lung pulse? Is that pulsation? Not pulsation, right? But you can confirm that no sliding. No sliding. But what is this? Breathing. The chest wall muscle contract instead of lung pulse. Because sometimes if you interpret it as lung pulse, you will think that the patient doesn't have pneumothorax, right? That tricky part. Can't you find the lung point? Yes, right? So it is the highly specific sign to diagnose the pneumothorax. Where can we find this location depends on the patient's need the chest tube, drainage, or just observe. Because if you see the lung point only located in the anterior chest only, that means the pneumothorax is minimal. But if you can only find the lung point outside the anterior axis line, even to the posterior lateral side, that means the pneumothorax is quite large enough. You need to manage immediately. After the intubation, after the pigtail insertion, we can also monitor the response from the lower part to the upper rib and to even the one upper. Sliding, pulse. And then the lung point, and then no sliding. I would like you to observe this. This is not actually lung pulse. It's kind of expansion, touching, then disappear, touching and then disappear. Okay, still some kind of variant of the lung point. And the heart probe, right? What is this view? Power standard long axis, right? So what is this function? Zoom, right? To amplify this regional region. Just like if you are trying to measure the LVOT, or if you are trying to see the valve problem, these patients, we have to incorporate into this patient's clinical presentation. A middle-aged young man got drug abuser and got fever, septic lung, and murmur. What do you see? Vegetation on the aortic valve, right? Here, echogenic material just floating and attaching on the aortic valve. If the patient's got hypotension, what do you see? Do you need to give more fluid? No, the fluid status is acceptable, or the patient's the compliance is poor, right? So you have to manage the other way. How about this situation? If the patients develop hypovolemia or hypotension, even hypotension, what can we do? Fluid. Why? Because you see, collapse, kissing of the IVC. So that means the patients can be resuscitated with fluid first. How about the heart? Contraction is good, right? So you don't need to add the inotropic agents. So can management and guide your resuscitation. Young, really young, less than 1 year old. What are we doing? Chest compression. We are doing chest compression and do the skin from the subxiphoid to without interruption of the chest compression. So after our resuscitation for 1 hour, no response on the no pulse and no tracing, and then What do you see? No contraction at all. So this resuscitation cannot resuscitate this baby. So we termination with this and recording. An older one, but a trauma one. What do you see? Where is the location? Right upper quadrant, Morrison's pouch. What do you see? Free fluid. How about the content? The content looks anechoic at this part, right? Okay. Now, based on standard procedure, we should check the other side. What do you see? The diaphragm, right? Do you see free fluid? A lot of fluid. Minimal. Minimal. So, this is fluid. And these are all clotted blood. This is the liver, spleen, right? The spleen. These all are blood clots. What do you see? The pelvic region, right? Transversely. This is bladder or ascites. Bladder. All of you think this is bladder. Okay. See? Is that bladder? The same. I just scan here transversely to produce this image. So every time we have to scan like swiping, tilting to see the whole organ, whole the interface. Otherwise, you will misinterpret this as bladder, but actually it is ascites with clotted echogenic blood at the dependent part. Then move to sagittal way. The patient's got catheter inside, right? So it's free fluid. Sometimes we will see the patient's bladder is collapsed. So we have to check these regions in different axes, transversely and longitudinal way. Then move back. So if we are trying to teach and trying to recognize the echogenicity, the beautiful of the B mode, the brightness mode, see this one. Anechoic, isoechoic, hypoechoic, hyperechoic means normal, free fluid, echogenic fluid, and disruption of the content, echotexture of the spleen, right? So that's the splenic rupture here. And when we compare to the non-enhanced CT scan, we can see hyperdense of the clotting. After contrast enhancement, still we can see these structures. Then 15 years old girl got right abdominal pain. Center location, transversely to scan the hurting areas. What do you see? Iliac source muscle, right? What do we see? Appendicitis. What is the appendicitis look? Straight, circular, circular one. The second, this one is a tube with pericysis, so that's terminal ileum. See the end. Then back. Okay? So every time I scan the appendicitis, I will scan transversely to see the root and sometimes to see the the movement or the rotation. The appendix, see again, transversely, iliac source muscle. Here is the tube. So upside down. Just seek for this. Because time limited. So what do you see? iliac crest, so small, so iliac vessel, quickly, so standard position for appendicitis. Do you see the appendicitis? This one, transversely, move toward the pelvic part, right? Transversely, lateral medial to the lower. After you see the root, rotate to its path. What do you see? Call it appendicotic, dilated blind-ended structure with echogenic content surrounding, right? So this is appendicitis. Abscess or not? Abscess, right? Cobblestone, abscess, pocket one, and abscess, right? Okay, confirm it. Then, if we are doing the procedure, confirm this one, is free air or the instrument. See? The instrument, the screw, some materials will cause some kind of shadow, like this one. But the beautiful is we can compare the both sides for most of the musculoskeletal system. Here we can see a lot of fluid around the processed materials. So we can confirm it, avoid the vascular structures to identify the safe way. The joint, the elbow joint, echogenic material inside. So, because this is superficial part, so if you are trained to do this, you can do it real time and can to see the response and can to monitor the result of the treatment. These patients, initially I consulted plastic surgeon to do the debridement because I'm thinking about if that is some kind of necrosis or some kind of necrotizing abscess within the patient's swelling elbow. But the plastic surgeon is not available immediately because do some kind of microsurgery. So I do it my way. Put the needle flat, as you can see, the angle, if you put the needle parallel to the probe, the enhancement is stronger, can let you see the needle easy. Monitor response so the patient is sent home after the aspiration. The patient got foot crushing injury, so I have to do some kind of pain relief because the pain got NSAID, got morphine, still yelling in my department. Everyone in the emergency department is wondering what can you do to manage these patients' conditions. See here, what do I do? This is the patient's lying supine, and this is the popliteal artery. This is the sciatic nerve. So we are doing the nerve block transversely and put the probe close to the nerve and then inject the lidocaine around the nerve to provide the pain relief.
Oh.
Don't remember physical examination.
Okay.
What is this? Positive Thompson test, right? Means the patient's pain is because of the problem of Achilles tendon, the superficial one. So if you are scanning this region, you have to use linear probe and definitely to scan in long axis way to demonstrate its separation. Here, we use ultrasound because you can use it to test dynamic status, just like this one. The distal end, the proximal end of the Achilles tendon, the disruption and the hematoma here, you can do it in a dynamic way to test musculoskeletal systems. Okay, the last case. Train your eye instead of ultrasound. Does anyone see the fracture? The patient's running in the school and falling down, the wrist just landing and then got pain here. The patient complained pain here and got a little bit, obviously swelling of the distal end of radius instead of snap box. So I believe my physical examination. So initially, I think the patient's got distal radial fracture. I write the suspicion on the X-ray examination order. But can you see the fracture? Here, instead of the other part. Fracture? No. Yes. Initially, my eyes tell me that the patient has no fracture, but my physical examination tells me that the patient's swelling, the hurting area, should have some kind of fracture. So I use ultrasound to challenge. See? Disruption of the cortex. Here is the gross plate. So when we enlarge, amplify it, see the fracture line here. Difficult, right? So sometimes we see these conditions. Most of the time, I encounter patients with refracture, but initially we miss that on standard X-ray and review. But the patient still complain. So listen to the patient. We use the linear probe to scan that region. Sometimes you can define that kind of cortical disruption. So, see these video clips from different sides. Initially, no fracture. Then I scan dorsal side, no fracture. The dorsal part of her left wrist. Then lateral side. Lateral side. So the dorsal side is normal. The lateral side got a problem. So the then volar side. The next one would be the volar side here. No fracture. So got incomplete disruption. So when we are scanning the musculoskeletal, especially for the bone, we can compare, but we also remember that sometimes incomplete fracture, you have to scan from different aspects. Comparison for the equality, for the local abnormality. Here is the direct evidence, and this is the blood just beneath the tendon, and then scan to the tip of the radial bone. Here we can see some hematoma right there. So the patient still got pain over there. Sorry. Okay. It remind me that the time is end. Thank you. No more question. We'll end here. Thanks.